Okay, so looking at the alveoli and the fact that they are very well vascularized, one of the areas that we're going to find in between an alveoli and a capillary is something termed the respiratory membrane. The respiratory membrane is going to be a single cell layer thick. It's going to have some water, which is basically going to be surfactant, which is a type of material that helps with the ability of the lungs to reduce their tension so that the lungs do not collapse in when we're breathing. So this respiratory membrane is very important. The fact that we are at an area that is a single cell layer thick, we're going to see that this is going to be the area that we're going to have the exchange of the gases. We're going to exchange our carbon dioxide and our oxygen. Now, as we look at the structure of the lungs within their cavities, we look at the lungs that are contained within the thoracic cavity, but the lungs are going to be found in what's called the pleural cavity of the thoracic cavity. So we're going to find that we have linings that are going to be around the lungs as a whole, and then there's going to be a lining that's going to run the length of the thoracic cavity, and it's helping to anchor the lungs, but it also creates a space between the lungs and the thoracic cage. So we end up having a lining that is visceral and a lining that is parietal. In between is going to be our pleural fluid. The fluid that is surrounding the lungs as a whole is like a lubricant. It helps to keep the lungs from actually sliding against the cavities as we breathe. The region that is the middle is termed the mediastinum. And as we, like if someone gets inflammation in this area, you may have heard of someone having pleurisy, and it's very painful. You're actually feeling your movement of your lungs every time you breathe. When we look at what's happening, pulmonary ventilation, the ventilation of our lungs, for every inspiration and expiration, this is termed a respiratory cycle. So each breath in, each breath out. We're going to see that the ventilation, the breathing, can be termed quiet or forced. There are quite a few muscles involved in respiration, especially the muscles in between the ribs, as well as that huge diaphragm. We do have some neural control of our breathing. In the medulla oblongata, we're going to have a respiratory center. We're going to find that we have what's termed a ventral respiratory group, a dorsal respiratory group, a pontine respiratory group. Basically what happens, there's like cross communication between these areas, and because we've got 1, 2, 3 groups, their job is to inspire, expire, and have a rhythm to our breathing. So when we look at the ventral group is very active when we breathe in. So we get a lot of our breathing in with the ventral group. Ventral group is both breathing in and breathing out. The dorsal group is mostly breathing in. Sorry about that. And what we're going to find with the pontine group, as we breathe in, breathe out, the pontine group is going to be able to fine tune the breathing, help to make sure that we have a good rhythm of our breathing. So as we look at the control of our breathing, like I said, in the medulla oblongata, we're going to have those groups, the respiratory center. We are dependent on chemoreceptors and some stretch receptors. Now, the chemoreceptors are going to be very responsive to oxygen, carbon dioxide, and pH. Those chemoreceptors can respond to any of it. We're going to see that we have central chemoreceptors, which are in the medulla oblongata. The peripheral are found in the carotid and aortic areas of the body, meaning the branching that comes right off of the heart. They're connected to the respiratory center, and they are going to help to send information so that we can breathe. For example, if the pH in our blood drops, we start to breathe more so that we can get rid of CO2. If the pH in our blood increases, what we're going to do, respiration is going to decrease. I think I might have said that backwards. Let me try that again. If our blood pH drops, respiration increases so that we can get rid of CO2. If our blood pH increases, our breathing decreases so that we can raise the CO2. Each of these affect the pH of the blood. Now, in the lung tissue, we have something that's termed stretch receptors, and these are found in the smooth muscle, and we don't control this. So what we end up getting is we get a Herring-Brewer reflex, meaning this reflex, as we breathe in and breathe out, we need to make sure that we do not overstretch the lungs. So the stretch information gets sent to the brain, and this way we can breathe in, breathe out, and not overstretch that elasticity of the lungs. Irritant receptors are just that. Anything that's trying to make its way in, we're going to try to make sure that we get it pushed out. Now, some of the controls over our respiration are the pressure, the resistance, and the airflow. The pressures, when we talk about pressures, your textbook is going to talk a lot about the gas laws. If you're choosing respiratory therapy as your program, these gas laws are going to become very important. I'm not going to focus on these, but the laws that apply are Boyle's, Charles's, Dalton's, and Henry's. I will not ask you to do any of the math, but note that the gas laws, we have pressure and volume, we have volume and temperature, and then we have volume and total pressure, and then Henry's law, which is going to give us information about an air-water interface. Henry's law is important because this is what we have applying at that respiratory membrane, the area where we are going to see the exchange of the gases, of the carbon dioxide and the oxygen. So that's going to have a lot to do with factors on respiration. When we breathe, we know that we're going to have it start at the respiratory center in the medulla. because it's receiving information from receptors. The information gets turned into an action potential. This activates more neurons because of the pressures and receptors. We're going to see that inspiration is going to be controlled so that we do not overstretch the lungs, and that we will be able to breathe out and have a controlled rhythmic breathing. Now, one of the big things that you will probably come across in your programs that you're going into, and especially if you choose to go into respiratory therapy, when we talk about these factors for breathing, resistance becomes important, because resistance, well, if we have a lot of resistance on our breathing, the slower the airflow is going to be. So, resistance is affected by the diameter of the bronchioles and what is the compliance of our lungs. For our bronchioles, they can either dilate or constrict. And for the lungs, what is the ease in which the lungs and that thorax also are going to expand? So the easier the lungs and the thorax expand, the greater the compliance. A disease that you're going to probably see a lot of is emphysema. With emphysema, what's going to happen is it sounds like it's backwards. However, because of what happens with emphysema, we're going to see that we get a reduction in the elastic recoil of the tissues. Now, what this does, it actually expands those alveoli, but that decreases my surface area. So it seems like the person with emphysema, they're struggling to breathe because their alveoli have actually increased in size. And even though it would seem like that would give more surface area, which it does for better exchange of gases, taking away the smallness of the alveoli actually decreases the ability of the gases to exchange in the blood, and because of that, it creates that ability or that struggling of the person to be able to breathe. But we'll pick up at this point in class, and I will see you then.